Now there's a little change because Dr. Kini, there is some urgent tower patient and the live relay. So she's moving up a little bit. She'll present her topic. As you know, she's the director of cardiac cath lab and the system interventional director for structural heart disease program and fellowship program. Tremendous lot work in the lipid area with the yellow trial was described by Dr. Jagat Narula. But today, now we'll be talking on update in transcatheter mitral and tricuspid valve intervention, not the aortic, because everybody thinks the aortic is done. It's already to the interventionist, but in this area of the mitral and tricuspid, a lot are happening, and she'll update us. Anu?
Yeah, thank you, Dr. Sharma. Good afternoon, everybody. And I think will be a big switch from some cardiology topics to some kind of interventional topic, mostly procedural. So, like you mentioned, I'll be just talking on two valves. So, once upon a time when we were growing up, when anything to do with the valve used to be open heart surgery. But if you see here, this is how it started. 1989 was the first stent valve, and subsequently it was Alan Crebier who did the first in man in 2002. Was in high-risk patient that we did percutaneously. The valve, instead of opening the chest, it was done percutaneously, and since then it has now come to low-risk population. So the four valves, like we all know, I'll be discussing the two of them, which is mitral and subsequently tricuspid. So starting with mitral regurgitation, we all know the presence of mitral regurgitation with or without LV dysfunction, the mortality could be up to 57%, and same, mitral regurgitation begets mitral regurgitation. Very simple, that surgery is offered just over half of the population. So as the age increases, the number of patients who are going for surgery actually has gone down, making that there are a lot of people who are not being offered treatment, and these people do poorly and survival is bad. Very basic, the two kinds of mitral regurgitation. Primary, which means there is, it's called degenerative, there is some anatomical problem with the mitral valve, some issue with the leaflet, subvalvular apparatus, or chordate tendinae. And if you see that, this is the primary, and then the rest could be secondary functional. That's a problem with the muscle, which leads to annular dilation and subsequent mitral regurgitation. So we'll go one by one. Primary, this is what we see, and what the guidelines are, which came out in 2021, that certain echocardiographic criteria and symptoms or no symptoms, mitral valve surgery is the class 1 indication. So for primary mitral regurgitation. Then, like I mentioned, many patients were not getting treatment. So subsequently what happened was that after trials, that patients with high and prohibitive risk with favorable anatomy, then FDA approved in 2013 what we is called a clip procedure, where we can do it transvenous procedure in these patients. Again, we have to be very clear, high and prohibitive risk, and low risk means they go for surgery. Going to secondary mitral regurgitation, what did the trial show? That if you have secondary mitral regurgitation, that means you have LV dysfunction, functional mitral regurgitation, first and foremost, they need what is called as guideline-directed medical therapy. That they need to be on medical therapy, because many of these patients, the mitral regurgitation improves and feel better when they get guideline-directed medical therapy. And later on, if they still have symptoms and meet the criteria, they can get a clip. And FDA approved for secondary mitral regurgitation in 2019. So cardiologists who are here, when you see a patient in your office, what do we have to do? You have to do in these patients, you listen, you hear a pansystolic murmur. Of course, the first way to make sure that they have mitral regurgitation is transthoracic echo. Then we need to define, like I said, the etiology, whether it's primary or secondary, and subsequently can then go to other tests. So before doing this test, you can then consider them referring to the tertiary care center like here. And usually there is a heart valve team or heart team like we call, which includes imaging expert could be echo MRI, interventional cardiologist, a surgeon, usually could be a mitral surgeon, nurse practitioners as well as anesthesiologists. All of them actually see the patient, risk assessment, make sure they're on therapy, and then decide what should be done to this patient. So this is actually the guideline that has been given. So what are the guidelines? I think some of this may be covered later on by our colleague for heart failure, but we have to make sure that patients are on. Most important is Lasix plus minus ACE inhibitor, SLG2 inhibitor, but the trials were beta blocker, Lasix, which were diuretic, plus minus ACE inhibitor, and hydralazine or nitrates. So they got to be on this therapy and still continues to have symptoms. That's the time you refer them to us. This is to show you a case presentation where this was a 79-year-old female at the dilated cardiomyopathy with EF of 25%, multiple comorbidities, who had dyspnea on exertion, lower leg edema on medications, and continue to have symptoms. Echocardiogram showing moderate to severe mitral regurgitation. 3D echo, you can see a combination of prolapse, and there was some LV dysfunction also. So it's a mixed pathology the patient had. So percutaneous, so mitral valve is on the left side of the heart, so we got to do a transeptal to go to the left side, and once you go through the regular sheath, this is where we are able to go and place the clip on the mitral valve. So you start with one, you see what happens to the mitral valve, especially the regurgitation. Also, you make sure you have not caused stenosis, that there's no gradient, and if you think that regurgitation continues, you will place 2 or 3 clips. And this is an animation that's showing how this works. So this is the final. If you see, we started with the V wave, which is almost 80 millimeters here. Subsequently, after 1 clip, went down to 50, went down to 35, and finally we were able to place 3 clips and bring the mitral regurgitation almost to mild. And we always tell the patient, so this is not a treatment where, like surgery, where you go in and you come out with almost a perfect result. Usually you bring it down by 70-80% and continue the medical therapy. That way they will have some benefit. So 2 important randomized trials that were related to secondary mitral regurgitation was COAPT and MITRA-FR. They actually were presented back to back, had different results. So if you see here, different results for this was 1 year and this is at a 2 year, where COAPT was used for secondary mitral regurgitation, that you see a definite improvement in all-cause mortality. The trial first time showing that there was an improvement in mortality in patients who got clipped, but this particular MITRA-FR showed no difference. And why the 2 trials had different results? COAPT trial enrollment was very strict. Patients were almost severe mitral regurgitation, and everybody had to have guideline-directed medical therapy. Once guideline medical directed therapy was done, heart failure cardiologist was involved. They continued to have symptoms, and moderate to severe MR was still there. They were the patients that were enrolled. And less advanced LV dilation and dysfunction, which means not like burnt out LV patients were presented. That is why we saw a difference in the trial results in this particular case. So actually, if you see here, the 5-year results were actually presented recently, and you can see that even at 5-year, hospitalization for heart failure, death for any cause, as well as combined, everything was different. And what actually happened is, after 2 years, you could see that there was a crossover. So you saw the difference up till the crossover, and once the crossover happened, there was no difference between the 2 groups in this case. And then when they did a sub-analysis, everyone, there was a benefit in every subgroup analysis when it came to device treatment. So the conclusion was same, safe, and led to a lower rate of hospitalization, heart failure, and all-cause mortality, not only at 1 year, 2 year, but up to 5 years. Now, then what happened is there is those were the first generation, second generation clip. We have a 4th generation clip, which means that if you see here, they became wider, because when we go for secondary mitral regurgitation, many times they are dilated and we need to capture more, and even the length increased. So what they did was, this was at 30-day, which showed that the mitral regurgitation definitely was lower, and 1-year outcome with the 4th generation mitral clip in this study will be presented in TCT. So that clip was from Abbott, and subsequently Edward also came up with a different clip, and the study they did was CLASP. So once you have one particular device that is approved by FDA and another device comes up, they need to compare with the first device. So that was exactly what happened. This was Pascal. When the device first came, they had to compare with the Mitra clip system of the Abbott, and this was their original one, where they did the 30-day outcome as well as a 6 months outcome, which was comparing the two. No difference, but essentially we know whenever there is a new device, there is always a learning curve. So procedure time was slightly higher with Pascal, but will be no difference. And Pascal was approved in 2022 for, again, degenerative mitral regurgitation, not the primary, the secondary. And the 1-year outcome of the same trial will be presented again at TCT. Just to give you an overall, the procedure numbers that are done in the United States regarding to the mitral clip. So if you see here for secondary MR, primary MR, so in 2019 was about 10,000 procedure, and we predict in 2022 and 2023 it will be above 20,000 procedures, and will take both secondary and the primary. This is here cyanide numbers, which is including clip for mitral as well as tricuspid, which is half and half, I would say here, for the kind primary as well as the secondary MR. Probably we may go above 100. That is Dr. Sharma's prediction. So we always compare ourselves to ourselves, but you have to compare yourself to the nation. So if you see here, every procedure that we do, which includes the PCI as well as the tower and the clip, we are part of national data registry, which is called as a TVT registry. So if you compare to the nation, our MR reduction is better, and gradient is also lower, and more important is the procedure time. If you see here, nation takes almost 1 hour to do the procedure. We are about 25 minutes in doing this procedure, but look at our outcomes compared to the nation. Excellent results at 30 days as well as 1 year. Just moving on to, that was just the clip which we showed you. So is there something else can we do? If the patient is not a candidate for clip, can we do percutaneous mitral valve replacement with a valve? Yes, but who are the candidates? So valve in valve, that means they already had a prior mitral valve, and now there's a failure of that valve. Valve in ring, where the patients have calcified annulus, so it's called MAC, mitral annular calcification, as well as other one is the ring, that instead of valve, they had a ring procedure in the past, and those are the various valves that we have been using. So it is not as simple as mitral clip, in the sense the anatomy is slightly different. So when you place the valve, the biggest concern interventionalists have is that there will be what is called as a neo LV that is created. It's called LVOT, that this particular valve will go and obstruct the outflow and now cause LVOT obstruction, causing more issues rather than improving. So patients need to have TE and CT scans to understand, can a patient get this particular valve? And I'm also going to show you that there are various kind of valves. So other one, what I mentioned was mitral annular calcification. So you need evaluation of MAC by cardiac CT as well as by TE. And then we decide, can we do a valve in these patients? So if you see here, if you want a percutaneous valve to stay there, usually why does a percutaneous valve stay in a position when you place that? Because there is calcium that holds on to the valve. So you need to have 360 degree of calcium around there. So if it is less than that, we know that the valve may not stay there and may not be an ideal fit for that particular candidate. So it's very important that MAC is being evaluated. This just came out last month, that this was for patients who are mitral annular calcification, that they created a position statement, which is a consensus. It's a very, very complex consensus statement. You can only go with the color. That is, green is favorable, yellow is challenging, and definitely prohibitive, depending on the calcium as well as the way angle, which valve is probably suitable for which particular candidate. And this one is also a CT-based calcium distribution. It is not just a distribution and the thickness, who should get what. When you see number of devices like this, you know that it is a complex condition, in the sense that mitral valve is not as easy as aortic valve. Aortic valve is circular, this is oval, and very difficult to understand which valve can fit into which particular patient's morphology. So we are part of Medtronic Intrepid study. Initially we used to do apical, now we are doing a transeptal valve here. So this is the Abbott Tendyne valve, which they did a transapical. First 100 cases showed that it is feasible and doable. And right now they're going to show the MAC arm for the same valve in TCT. And we are part of this Apollo, where we are doing transeptal part. It is still ongoing study. So this is a primary cohort, and then there is a MAC cohort. Like I mentioned, if they are just a mitral annular calcification, can they get this particular valve through the transeptal here? So if you see here the initial study of 30-day outcome, just look at the sheath size. Was initially started with the 35-hour regular angiogram we do with 5 French catheters, and look at this 35. The size is really large, and this is a venous procedure that we have to do, go transeptal and do that. So 30-day outcome was good. So the question always comes when you guys refer cases to us, and many of you do call us and ask the question that is a clip possibility, or does this patient fall into mitral valve replacement? So that is why this heart team is very important. That echocardiographer who will look at the transthoracic echo, TEE, and plus minus CT scan, then we make a decision, is this candidate, is this patient suitable for a clip, or this patient should go for TMVR. All depends on the mitral valve area. Small area means we know we cannot place a clip because we will cause mitral stenosis. We need to have enough leaflet length so we are able to grasp the leaflet. And also same thing, if for TMVR, like I mentioned, we cannot create LVOT obstruction. These are all the important features that we consider, and then say which patient should go for which device. Some of the ongoing trials, initially we just use the device. Now we are going head-to-head comparison with surgery. So repair MR, which includes primary mitral regurgitation, and patients, if they are at least 75 years, so we are talking about intermediate risk patient with some kind of STS score involved, and they are randomized to clip versus open heart mitral valve repair. And in primary, all patients, all means low, moderate, high risk, all risk patients are included. 450 patients will be included, will be again surgical repair with versus clip. So these trials are ongoing for the results in the future. So quickly to say, just to finish only mitral, that mitral clip has been approved both for primary as well as secondary, and most important is the secondary, where heart failure patients who are on therapy, who still have mitral regurgitation and ongoing symptoms, they do feel better when they get the clip. And we showed you the results of a transcatheter mitral valve replacement. Trials are ongoing, and we'll be discussing more probably next year. Moving on to tricuspid, if you see the tricuspid prevalence, the combined prevalence of AS, MS, AR, MR is right here, but tricuspid, almost 2/3 of the patients do have tricuspid regurgitation. And it's more with age, if you see that, similar prevalence of AS. This is worse than mitral regurgitation when it comes to treatment. Prevalence about 2.4 million patients in the US. And look at the treatment that patients get, only about 100,000 surgeries. Most of them are on medical therapy, and medical therapy includes only diuretics. And of course, since they have concomitant other comorbidities, they can have other treatment, but otherwise none. But 0.4% are treated surgically today. So there are a lot of patients up there, and they are very symptomatic when they come. They have symptoms of shortness of breath, leg edema, ascites. These are the patients who are real tricuspid regurgitation. Again, complex anatomy, if you see here. Anterior leaflet, posterior septal. And then also what very important is there are other important structures around here just compared to mitral regurgitation. You have coronary sinus, then you have your AV node as well as your circumflex, native circumflex vessel, which is also very close. And the most challenging part is the imaging. It's not that easy to do either a TEE or eyes to see this valve compared to mitral. Once you do a TEE through the esophagus, we are able to see the mitral valve much easier. So it's same thing. When you see a tricuspid valve, first thing what you see is it is not as muscular as left ventricle, so the dilation happens where there is least resistance. So you start seeing the RV dilation, right atrial dilation, and all these things happen. And I think that this is from our medical school, pathophysiology of functional TR, means most of it is secondary and from the left side, either from the pulmonary disease, but more often is left-sided disease. There's increased pressure, goes on to the right side, and on top of that, very rare, it could be just atrial fibrillation, and that can also give rise to right atrial problem. So if you see primary, only 5%. Majority of the patients are secondary, which is pulmonary hypertension. Primary secondary to left-sided disease is more common than what we see. And what are we interested in is this is the newer classification. We used to only talk about severe, but now they have gone to massive and torrential. Torrential means essentially you see the it is just an open valve where you see a lot of regurgitation. So guidelines are severe TR, stage C and D, what we just showed, and at least left-sided valve during that surgery is you do class 1 at that time. During left-sided valve surgery is a class 1 indication for that particular disease at that time. But in ESC guideline, if you can have primary TR, and if they're symptomatic, they can also undergo surgery. But if the mortality for the treatment of tricuspid valve surgery is still very high. And there's no one way of treating, even in surgical field. If you see here, there are multiple ways of annuloplasty, replacement, or just figuring out the cord. So in hospital mortality, almost, I would say, 8.8 in these patients. So they're very sick patients. Even when they undergo surgery, mortality is very high for these patients. Transcatheter treatment wise, if you see, multiple devices. So there's a cooptation device. This device is a cable device which we are part of this trial, and we are going to be starting that you place a stent in the inferior vena cava. That's how it's going to start. Annuloplasty, ring annuloplasty, and TTVR. So I'm going to discuss the clip like we do for the mitral. The similar way we can place a clip in the tricuspid, and we can use valves on the tricuspid side also. So this was presented recently, and if you see here, exactly the mitral, but they created special clip called as a TriClip, G4 delivery system, which was used on the tricuspid side, 1-to-1 randomization of TriClip versus medical therapy in this patient, and they were followed for 1 year. So this was 30-day and 1 year device versus control in these patients. If you see here, green means less TR, where definitely decreased TR in patients who got device. So what they did was KCCQ change, means essentially asking the patient how did they feel. That was the only difference that they found, rather than death or hospitalization changes in this patient. So important thing was it was not blinded. So when it's not blinded, patients whenever I think that could be a placebo effect also when they get this device. But the further Tricuspid safety data will be presented for 1 year, one for the in the TCT coming up. So replacement wise, we are going to talk on one valve. There are several valves that are out there. Evoke is the valve that was a 2-year outcome that was presented here. First, so this is the 30-day where you can see this valve was very safe. You go from the inferior vena cava and you're able to place the valve with the device. How you see it. So procedure success very high with the good symptomatic improvement and very low complication. This is how the valve looks once it has been placed. Echo. This will be the trial, the TRISCEND trial, which will be the same, that will be randomized for medical therapy versus the valve I just showed, and it will be presented as a late-breaking clinical trial in TCT 2023. These are the ongoing future studies of the tricuspid, which includes many of the things that I mentioned, the band, the clip, and the Forma device that was just discussed. So that will be, they are ongoing and will be presented in the future. So what can we say about tricuspid? That in selected patients, tricuspid surgery can be done, and same thing in selected patients, the clip can be done, and a lot of ongoing studies are there. And this is the landscape that I think Dr. Sharma predicts, that TVT means a transcatheter valve treatment. If you take percutaneous treatment in the future, in interventional cardiology, about 40% will be coronary, then will be peripheral, and the valve will probably remain at 35% or so of the total patients that we see. And these are just the final conclusions saying that, all these things are available for the patient. So when you refer the patient to us, very important that we see them in the clinic as a team, and then we decide who gets the best. And we just want to say, since it is a team approach, we always believe the good work you do, you get a better outcome. Also, like we just mentioned, we do a lot of teaching with live cases every month, 2 to 3, and they are archived on ccclivecases.org. And our next symposium will be the valve symposium that's coming up on December 7th, 2023, one-day symposium of all percutaneous valve treatment, as well as excellent lectures that will be presented. Thank you for your attention.